Good afternoon, everyone. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Siamish, and Simyamu people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. And the first agenda item is a discussion of potential surveys of providers, users, and of law enforcement and EMS about using the Ann Deacon Center for Hope Crisis Stabilization Facility.
So thank you, Jill, for reading that and updating us on the first agenda item. The discussion centered around really the use of the Ann Deacon Center for Hope, and the result of the discussion was that we were going to have a breakout session with some law enforcement members to make sure that everybody on the law enforcement side was kept in the loop on what services were available, where the ins and outs were, and that each of our team members in the law enforcement side of things have an awareness of what services are provided. And there were some small pocket-sized cards that were made available from Perry with the health department that had contact information. But we have not had, a follow-up discussion to date to make sure that everybody in the law enforcement segment is on the same page. So that there's more work to be done here, but the agenda item here is to follow up on that discussion. So I wasn't here for the initial meeting, and I can't tell who all is on this particular discussion, who's on the meeting right now. So would somebody jump in and help me sort through what's left to discuss about this topic, please?
Still here, Caleb, I believe where I recall this being left off was Raylene King was very interested in creating a survey specifically of law enforcement and EMS services about their use or not of the Ann Deacon Center for Hope. And we talked about putting together a survey, sending something out, which we can do via the council office on SurveyMonkey. I'm not sure what questions we would ask. I think that's something that this group would probably need to do a first draft of, and then maybe run it past the Law and Justice Committee to get their input as well. And then there was also discussion about possibly also surveying providers and users. And I believe Perry Mallory was going to talk to the vendors about doing an exit survey of the users of the Center for Hope. So I don't think there's anything for this group to do on that front. Yeah, that's where I recall the discussion left off.
Okay. And I'm going off of memory banks as my computer reloads.
Recording in progress.
Sorry. I got my computer to start right in the middle of all that. So once my computer gets all the way set up, I'm pretty close to being on my computer again, but I still have all the stuff waiting to load. So my memory is a little bit incomplete of what it was that we discussion points about who we can reasonably expect to respond to a survey if we didn't first let the law enforcement partners know about some of the information. Am I missing something? Again, my memory is a little bit incomplete on this. Go ahead, Chief.
Basically, part of the discussion was that there was a high probability that law enforcement was not going to engage in this process. And we did a little bit of reaching out. I guess it was primarily through one of the bureau chiefs meetings, but that the issues are that it takes too long to get somebody in, and that there are so many restrictive criteria as far as who can go in, that law enforcement has just made the determination it's not worth their time. But I mean, we can certainly do the survey if we'd like. I'm just not sure, A, we're going to get very much response, at least from law enforcement, and B, what it's going to prove one way or the other. But I could be wrong. So, I don't know, Jeremy may be able to speak more towards EMS, but
Yeah, that's what I was wondering about, Chief. So thank you for weighing on that. It didn't seem like there was a tremendous amount of understanding, I guess, first of all, from the law enforcement community about what services were available, but then there was some reluctance to use the services because, for example, if it takes more than 10 minutes to get somebody done an intake, it's prohibitive, and they would potentially go to other services as an option rather than dropping people off at the Deacon Center for Hope. So, as I understand the discussion, I'm willing to do what it takes to figure out what next steps might be, but I'm left a little bit to wonder what those might be. Jill, are you still with us?
I am.
Okay, so I got my computer at least to work, so I can see it on the computer. I can't get my computer recording to, or sorry, the camera to work.
Okay.
Can you see me as an additional participant in the Zoom twice? So like twice?
Yes, I have your video on our panelist group, and then I have your computer listed under an attendee link. So I hesitate to promote your computer link because I don't want to get that feedback again, but I can if you need me to.
Okay. Well, we can leave it like this. I just can't see anybody else. That's fine.
I can, sure. So today I'll just do a quick listing of who's here. We have Amy Fuller from the health department, who is part of the team that's going to present on agenda item 2, I believe. Dave Reynolds is here, Jeremy's here, and Wendy is here. And then for staff, it's myself and Jenna Grenant, who is also with the council office.
Okay. Excellent. So as far as next steps for this discussion, we definitely need to have that breakout discussion. I know Chief Tank is on the other call, but he was one of the ones who was willing to have follow-up discussion, and there was at least one other person who was willing to have follow-up discussion about, where we can go from here. And again, some of this may be stemming from the task force. So a little bit of bleed over. Again, I don't actually have my notes in front of me because the computer crashed, but some of this might be bleed over from the task force and what was going on with the task. I don't know if you remember any of that, Joe.
Yeah, that's I think that's where we left off with it. So I think in terms of next steps, as a staff person, maybe I would suggest just a conversation, Caleb, between you and Raylene to find out what her expectations are.
Okay.
And whether or not the index committee can help with that. And if there is a place for index committee to develop a survey, then the next thing we would need are a list of questions and that would be included on the survey.
Okay, excellent. So let's move then. We'll have that offline discussion with Raylene to make sure that we're on the same page. But let's move to item number 3 on our agenda, which is the Health and Community Services Department Response Systems Division tracking efforts. Are we ready for that?
Not quite yet. Melora said she will be jumping on at 2 o'clock at the end of the other meeting. So if you want to do a brief break, we can do that if Amy's got something and she wants to contribute before Melora gets here.
Okay.
Maybe Jeremy. Either way.
Yeah, if anybody has anything to contribute, I don't want to cut them off, but I would like to sort out my little technical issues if we're going to take a short break.
Sure thing. I figured, I know Jeremy and I were just kind of brought on as guest speakers, so we are at the ready whenever you guys, we'll just be on our computers waiting, so you can just ping us.
Okay. Jill, can we take a short intermission and sort out this computer issue with me? I think I'm close.
Yes, of course.
So Jill, if you can, I'll mute myself here. If you can promote me, and I will see if I can get that.
Yeah, we can do that. I'm going to pause recording here for just 1 sec.
So welcome back, everybody, to the Index Committee. We took a short break to allow other members to join from a different meeting that a lot of our membership was doing. We're at the point in our agenda where we wanted to take a look at the Health and Community Services Department Response Division data tracking efforts. That'll be a combined presentation from Laura Christensen and from Jimmy Morton and Amy Hockenberry. I want to find out from Melora and crew, are you guys willing to let me do our public comment period first? We have
Sure.
an attendee who's got their hand up.
Yeah, absolutely. I think we're all a bit flexible, so.
Okay, good. And as people are coming off of that other meeting, I want to make sure that we leave space for them to join too. So Jill, would you do the public comment, please?
Yes, of course. We do have one attendee with his hand raised today. Jason, thank you for your patience and go ahead and speak.
Hey folks, good afternoon. Jason DeForest, local business owner. Reason I had my hand raised, I have all my notes from the last meeting, and I just wanted to say you were about right. We were on that issue of the survey. I also threw out there in that last meeting that we need to make sure we hold the law enforcement and hospital staff accountable for doing these things, surveying the people that are actually having these interactions with those folks.
That's right. Yeah, no, thank you for that, Jason. I remember that specifically, that I called that out in the report out to the task force because that was a good portion of the note. So I very much appreciate that comment.
Not a problem, sir. Thank you.
Thank you. So I do very much appreciate Jason's points there, because that was something that was again stood out to me when I was recalling all of these discussion points to the task force. So very good. It looks like we have Maya just joined us. So we have enough folks that I think we can go ahead with point number 3, which is Melora and crew.
Thanks, Caleb. Hello, everyone. Melora Christensen. Nice to see you here. My role in the Response Systems Division is as manager, and I have the privilege of working closely with one of our other divisions at Health and Community Services, which is the Community and Organizational Development Division, or COD. And that's a newer division that was kind of when the health department was restructured. Includes our communications team. It includes our health information and assessments team, which we call HIA, as well as some other pieces that serve the whole department. And as a response systems division came into county government, added some programs. The relationship with HIA has just been essential and very positive for us, because data collection, data analysis, and program evaluation is something that we really struggled with when Grace and Lead were operated by Seymour Community Health Center, because we didn't have a data team, and we were lucky to be able to work with Jeremy Morton, who at the time was part of Whatcom EMS. And now Jeremy is part of the Health and Community Services HIA team. And so that's been a wonderful continuance. I just can't speak highly enough of these professionals that get to help us look at our programs, make sure we're collecting the right data, make sure we have the infrastructure to analyze the data, and then to be able to talk and tell our story. And as community-based programs, is it serving the need that the community asked for? Are we better off because we're doing this? And if so, how? And so I don't have a huge report for you today, but what I do want to share is the process that we're going through, so that we can be able to share those quarterly and annual reports, not only with the council's electeds and Incarceration Prevention and Reduction Task Force, but with our community as well, because we know that that has been an ask that we haven't been able to fulfill. And of course, we've been collecting data this whole time, and we just need to be able to analyze it. So I'm just going to tell you really quickly some of the advances that have happened in the past few months, and then I'm going to hand it over to Jeremy Morton and Amy Fuller, who are going to talk about their specific role in this process. So just a reminder, close that. We operate Grace, Lead, Mental Health Court, the Alternative Response Team. We're launching a co-responder program with the Sheriff's Office, and we have a nurse practitioner program as well. So those are all under the umbrella of response systems. And then we also do quite a bit of contract management for behavioral health services in the community. One of the things that we have been focused on over the last 2 to 3 years, but really concentrated this year, is having data sharing agreements with the entities that hold data that we know is connected to our work in these programs. Because again, we can't analyze anything if we don't have that full picture and the visibility. So we have been working on data sharing agreements, or DSAs, with the following entities. So we already have a DSA, an interface built with EMS, and that's it's called ImageTrend, is that product and platform. We have a interface with the jail booking platform. We are in the process of building out the data interface with the Whatcom County Sheriff's Office and Spillman, with the 911 CAD system. We're in communication right now with BPD about long arm, and we're working with the prosecuting attorney's office on their new software called Carpel, and also JABS. And of course, the one that we're still trying to crack is Peace Health, so that we can look at hospital utilization and how these programs might impact people going to the hospital. So any questions about DSAs or that? And of course, this is using our platform Gelada to build those interfaces, so that we can then see that data across all of the systems. Okay, so with that, Jeremy, I'm going to hand it over to you.
Hello, my name is Jeremy. I work for Whatcom County Health Community Services. I am the informaticist for that team that supports the response division as well as other teams. In general terms, let me share my screen here. And this is kind of an overview in 8 minutes or less. Close that, and then we're going to open this guy. And some of this is going to be duplicative for a lot of folks, just because there's a lot of moving parts to this work. This is information coming out of working with the sheriff's office, and this is a vast oversimplification of how individuals move through these systems. Anecdotally, we're aware that individuals do impact multiple systems over the course of a year. What we have not had in the past is a way to quantify that. So we have all these stories, we don't have any numbers. And what those numbers do or do not mean to the community, we haven't been able to tell. And all of my work has been around building the information infrastructure. And that's everything from Melora's point, data sharing agreements, all the way down to the row and table access level. So we can use reports for operations, use reports for annual reporting. Reading left to right, we have a population of people that have issues with medical health, social, economic health, and legal issues. 911 system is tripped off, at which point these individuals move around the system. My role is to figure out how to make information out of that. At this point in time, we don't have as much information as we would like. Hence, a lot of the statistics we have are very much specific to individuals and from the program's perspective, because these systems are big. The red circle there in the top left-hand corner is just the booking system. We do have an interface with the jail, and I can look at the number of folks that are or are not booked. And we aggregate that against folks that are involved in the programs, and we can run metrics. The section that is there circled in purple, in that kind of oblong shape, is parts of the justice system. That is work that is in motion involving mental health court and building the same kind of interfaces and very specific data analysis tools so that we can look at the court system. Because we, again, anecdotally know these systems all bump into one another and they'll work together. What we don't have is any, at the moment, the infrastructure to have visibility on all of it. We do have is that little bit there in red. An example of that, and the reason why we're doing a lot of the work we're doing, is this is looking at the sheriff's office code from 2019 to 2020. And this is how those teams categorize that work. This is working with Officer Gum and looking at, from their perspective, well, how do you guys classify these kinds of calls? The coding for it is actually objectively fascinating. There's a lot of things that law enforcement absorbs in terms of work inside of the community. The reason why this matters is that we can take raw information, we can structure it, and then get information out of it. And what that looks like is, reading left to right, we have the CAD system, or computer-aided dispatch, which is the WATCOM. In the middle, we have information from law enforcement reports. On the right-hand side, we have EMS reports. And there's the parable of the blind men will have a hand on an elephant, and the description they're giving is all correct, but it's all different parts of the elephant. And taken individually, it makes sense. We put it all together, it gets kind of confusing. So the goal is to get as much information to create a clear picture of what is and is not going on. The purple section there in the middle is a good example. On the left-hand side, we have a call that comes in 911. Computer-aided dispatch says it's a traffic incident. Law enforcement, it codes out as mid-risk, mid-skill, and it involves driving while license suspended, obstruction of justice, property damage. Not a great afternoon. EMS, they're on the exact same call. They're seeing headache, neck pain, treated and released per protocol. All of this information is true, but up until very recently, we have not had the ability to look at this information in an orthographic or in a longitudinal sense and draw any meaningful conclusions. What that looks like in a micro sense, this is work based off of the lead, Tommy, and he's been going through and by hand looking at the 24 months before and after someone is involved with the lead program, after their enrollment ends, and measuring the number of police contacts they have with Bellingham Police Department. At a 100,000 foot, the population of folks that have been enrolled in lead and have left the program, they had a combination of 782 contacts with Bellingham Police. After they had left the program, that number was 218. The general reduction is 72%, give or take. And that's just someone going through and doing it by hand. A lot of my work is going around automating this process so that we can have dashboards not only for decision makers, but also that we can actually draw very accurate pictures of what is and is not going on inside of our community. This is, again, looking at the jail interface. This is looking at the number of enrollments that are closed, a little infographic there. We separate this out into points in time because as individuals move around systems, they don't do so very neatly. And in line with the month or the year or the fiscal year, it's a lot of moving parts. But in general terms, when folks are engaged in services with the information available to us, they leave the program, their utilization drops. The ultimate goal is to draw a much clearer picture of the entire community. using the same technology, and this is looking at the LEAD program. I don't love it because we actually don't have any unifying metric. If I'm counting EMS encounters, interactions with police, or interactions with the homeless, there's no unifying unit. There's no time. Dollars is the closest thing we have, and it's not the best thing, but it is recognizing that these populations impact systems, and there's a cost in terms of money, time, resources that go into that. And our goal, at least from my unit's perspective, is to be able to tell decision makers in the public in pounds and ounces exactly what a population's impact is before they're engaged in services and what it looks like after.
Thanks, Jeremy. To Jeremy's point of what we're doing manually right now. Director Everbeck at Whatcom 911 sends us little snippet reports from CAD because we don't have that interface yet. We're working on it. But we get to see pieces of the data, but we're not able to fully analyze it and provide the information that the community is asking for. So just an example of something that we're getting from Director Everbeck and the alternative response team. She compared the program a year ago to the program now. And that's the alternative response team has a community connector that is a health and community services staff that's there at 911. So dispatchers determine law enforcement is not needed at this call. It gets transferred to the community connector, and then the community connector can dispatch the alternative response team. And so just to share a number that we have, which again is just the snapshot, is that a year ago, in a 3-month period, there were 96 community connector incidents. 13 of those were referred back to law enforcement, and 64 of them went to ART, to the alternative response team. This year, so now the program is moving out of the pilot phase. In that same 3-month period, there were 327 community connector incidents. Only 3 were referred back to law enforcement, and 305 of them went to the alternative response team. So that's the type of information that we all need as policymakers to determine, are these programs working? Are they meeting the need which caused us to create these programs? We can't have that conversation without this information. So I'm going to ask Amy Fuller to share her work with you all, and just very excited about the program evaluation piece of this.
And I'm muted. Good afternoon, everybody. Hi, my name is Amy Fuller. I am the Performance Management Specialist with the Whatcom County Health and Community Services Agency. Can you guys see my screen? Okay, should see a picture of a lot. Thank you. Okay, I got a thumbs up. Thank you. So I just wanted to talk a little bit about my role within the health department, what I do for the health department in general, and how it specifically works with Melora's programs, and what we're anticipating and hoping to produce for the community over the course of the next year. So I wanted to start out by just clarifying what we mean by program evaluation and how that is different from works in conjunction with what I do, which is performance evaluation. And I know that usually when people hear program performance evaluation, and they get a little glazed over. So I like to describe it in layman's terms so people understand that this isn't necessarily really complex stuff. It's really just about clarifying the type of work we do, what's coming out of that work, and just like Melora was saying, what are the short-term and midterm immediate impacts that we're seeing from the work we're doing. And then ultimately, we're going to do program evaluation, which looks at the community level impact that our programs are having. So in order to do that, we have to be really clear that we're collecting the right data to tell the story and to drive that decision making. So this is what we use in public health to evaluate any of our public health programs. It's your standard logic model, which it starts with the inputs, which are basically, this is the gas that makes the car go. It defines how we do the work, any limitations to the work that we can do, how much funding we get to do the work, the staff we get to do the work, all the things that make the program go. And then of course, the business processes and procedures. This is how we do the work. So we define what needs to be done, how we do it. And then once you push go on the program, you ultimately can start collecting data at any point. And that immediate data that we're looking at is that how much are we doing? So just basic outputs. How many people are we serving? I like to call these our McDonald's numbers. How many people served? How many types of activities are we doing, and what are the outputs of those activities? So, different programs are going to have different specific types of activities. LEAD is going to be different from GRACE. GRACE is going to be different from ART. So we want to make sure those numbers are activity specific. But there are going to be some numbers that are going to be shared by the program. So, the types of people that we're serving by demographic types, by mental health diagnosis, by interactions and arrest records, interaction histories with law enforcement. So there are some commonalities that we're going to be tracking across programs. So there's the how much are we doing, and then there's the how well are we doing it. So that's taking all of these counts and that's putting them into context, right? So we could report out numbers until we're blue in the face, but until we put those numbers into context, it's not going to mean anything to anybody. So putting those numbers into targets or benchmarks, did we do as well as we wanted to, or did we do better than we thought we would do? We're also looking at, your basic measures like how much money was spent. Did we overspend? Did we underspend? How much time is staff taking on things? And this is where we can do our quality control. So when we're talking about what I do for the agency, it's helping staff and leadership look at their numbers and say, okay, from these numbers, what's going on? Are there internal, external factors pushing up and down in these numbers? Why are we or aren't we meeting our targets? And if there are things that we can address from a quality control perspective, we go back to our inputs and our activities and we make adjustments accordingly. So this is the cycle of quality management, looking at performance management data and entering into QI cycles. But all of that, it's important to make the distinction that we're looking specifically at data that's produced by our programs from direct services to our clients. And we're not going to, essentially, when we're looking at what the type of impact we want to have on our community, we're not the only ones that are pouring numbers into that impact report, right? So we're part of a system that is trying to collectively impact. Essentially, we're looking at people in crisis in our community. So it's not just us, it's our EMS system, it's our law enforcement agencies, it's our hospitals, our ED units. So there's all types of agencies and people working on this issue collectively. But when we're looking at our quality management, we're looking internally at what we can control, which are the services that we're providing to our direct clients. But when it comes to working with our partners, we also know that you want to know how we're evaluating the impacts that our programs are having ultimately on this big collective issue. So, over a program evaluation is different from those immediate performance evaluation reports in that it's a research question, right? And I think it's done, it's mixed method. So we're not just using our program data, we're using outputs that can be generated by hospitalization data, by state level injury and disease and mortality outcomes, but we're also going to want to incorporate the voice of our community. So whether our clients are also our community partners and the public we serve. So we want to know from the agencies we work with, is our work impacting you in the way you need it to? Have we lightened your load in any way or made things better for you? We want to speak to the public and make sure that their interactions with our staff and the outcomes of our work is impacting them in the way that we said it would, or we want it to. So again, just the important distinction between program client data and population level data is very important. We're not going to measure the success of our programs using that population level output data. But eventually when we do that research report and program evaluation, we do use both types of data. So what this looks like in practice, I'll use the ART program as an example. We have, this is a what we call a line of sight logic model, which this is how we connect our program outputs to the overall community outcome we're looking to see. And for example, the activity that we're doing this, and again, this is a 30,000 foot view, a very simple summation, but art program staff are responding to diversion calls. Instead of police being called to the scene, art staff might be called to encounter a person who is very obviously in crisis in a public space and may be frightened and frightening others around them. And so we may get a business owner call in 911. And how do we measure how many of those visits we're doing? We're counting the number of clients we interact with. We're counting the number of calls we get. We're counting the number of service referrals we make for that person. We're collecting the type of needs we met in the moment for that person. We're looking at time and money spent. So those basic outputs, we're looking at that. And we do this so that people that are in crisis are kept safe in the moment and connected with the resources, the right resources that they need. So again, we're trying to avoid interactions that might escalate into a conflict, or law enforcement being involved when they don't need to be, or the person in crisis hurting themselves or others. So we're really getting them connected with the right type, the appropriate type of response. And the data we can collect on this is, again, we're talking about that quality control. This is something Jeremy and I have been working on this year is, we're looking at data outputs from our services and realizing that there's more data that can be collected in the moment. For example, a lot of our art staff are social service folks coming from an industry where they write a lot of narrative about clients so people can keep each other informed about what's going on. And what Jeremy and I recognize is that this is a moment where a lot is happening and they need to simplify their data collection. So turning things down into tick boxes, drop down menus. So we're really standardizing that data collection, goof-proofing it, trying to reduce the human error. And then we're adding technology so that they can collect that data in the moment instead of having to remember it when they come back, hours later after they've de-escalated and they're decompensating from what is usually a high stress situation, that they have to remember what happened in the moment and report it at that time. Now they can be doing it on site with tablets, or I know that's eventually what we're getting to. Sorry, Melora, I don't want to speak out of turn. That is the ideal situation. We're getting there. But again, that's where that quality control piece comes in. So we can really see if the data is not saying what we want it to. We look at all the root causes for that. And then we're looking at the things we can look at immediately are the number of calls where police interaction was diverted. We can talk to police and get feedback from them about how things are going when they do show up on scene. We can talk about whether or not medical attention was needed on scene or not. So the type of services that were needed in the moment. And we can talk about the type of service connections that were made. And then, of course, the intermediate outcomes and the things that we're interested in program evaluation. So we want to see these quarter to quarter, year to year, but ultimately when we're doing the program evaluation, we're going to look at these next two boxes, which is the intermediate outcome. Is anybody better off? So of our clients and our customers, are our clients better off in the moment? Are we seeing less engagement with the service systems? So less engagement with legal, less engagement with hospitals, EMS. For our community partners, so are we seeing a lessened burden on our law enforcement agents? Are we seeing a less of a burden on our reduction in inappropriate EMS usage, or ED visits, or any of that usage that we can associate? We can look at those usage rates. We can look at arrest records. We can associate return on investment cost avoidance, because the low estimates we've seen so far for a small number of individuals, we're looking at hundreds of thousands, sometimes even millions of dollars in cost avoidance just for 20 to 30 individuals, when we're doing a low estimate of the basic cost of the services that they are not engaging in because they were addressed by our teams first. So really important data to be collecting when ultimately we're telling the story of what is the goal we want collectively to achieve, not just as the health department, but as a community partner with all of the agencies we work with. We want people to have access to the support services they need, not just our clients, but obviously the public and the community. So, law enforcement isn't tangled up addressing things that they shouldn't be addressing. They're doing the jobs that they were hired to do. And then people ultimately feel safe in the community because they're not they're not being forced to engage in potentially dangerous situations or be in crisis and feel like they can't get help when they need it. So that's the ultimate outcome. And we measure this by, as a health department, part of our role is being a data hub and a data translator, and making sure that these data points are available to you as our community partners when we're looking at over time, did we turn the curve? Are we seeing decrease in death and disease in our community, certain very particular types? Are we looking at improved quality of life measures? And I know, Melora, you and I were talking about this earlier today. That's going to look very different for the clients we serve and the general public. So, we definitely are going to be looking at that as a health department about the different ways that we're going to define a collective measure for the community about quality of life. But these are definitely things that we can be looking at over time. And then, of course, improve public safety. So just, we getting a read on public sentiment about how things are going. Do they feel safe? Do they feel, and there was a public commenter earlier who said something about basically essentially talking about the voice of the customer, how important it is not just to get the voice of the people that we're serving directly with our assistance services, but also the community partners and the community members that are utilizing these services and interacting with clients in crisis. So how does this look in practice? Again, I put a little yellow star. This is where we're at right now. I started with the agency in 2020, January 2020. So as you can imagine, that was a pretty pivotal time to come on board. I think I was hired specifically to update and upgrade the public health's performance management systems and really looking at ways that we can modernize and standardize our data collection systems so that we're making data-driven decisions and being proactive instead of reactive and working smarter and not harder. Not that I'm opposed to hard work, but there's a lot the data can do for us that we're not using it for right now. So making sure that this is where we are right now. This is where we're focused, is standardizing our data collection so that ultimately we can create these program dashboards that Jeremy was showing you that make it really easy for our leadership and our staff and eventually our community partners to access data. Not all dashboards will be available to the public because that comes, and I do want to make distinctions in terms of when we're talking about data communication products, they need to go through a very specific process before we publish them because it will be defined by audience. A data communication product that I am creating for our management team versus for you as our community partners versus for the general public, they're going to look not very different, but they're going to have different messaging. They're going to have different tones. They might even have different formatting, stylistic choices that we're going to make depending on the audience we're communicating the data to and the messaging that we're trying to get across. So,
Hey,
but I
Amy,
want, yeah.
I'm so sorry to interrupt. I just want to do a time check. I know that we had.
Okay.
Oh, no, you're fine. I just wanted to check in with Caleb and see if we needed to wrap up or if we have a few more minutes.
We're good. You got a few more minutes.
Okay.
Oh, I can do it. I can do it. Okay, 90 seconds. So just saying that this data is rolled up eventually, like we're doing the regular reporting with data communication products. Ultimately, this is just our template, our balanced scorecard template for evaluating all of our programs at the health department, which is we're asking these questions about how well are we engaging our stakeholders in our work? How are we evolving and improving to meet our customers' needs? And again, customers in all three buckets, our stakeholders, our clients, the public. Are we managing our resources to sustain our work? And then how well are we supporting our staff to do the work? Because this is intense work. And when it comes to RSD programs in particular, these are the evaluation questions that we're currently designing our data collection systems because we want to be able to answer these questions in the coming year and the coming years, plural. But to what extent have our program outcomes contributed to the reduced utilization of emergency medical systems, decreased involvement with the criminal legal system, improved experience with law enforcement and for law enforcement, reduced workload for EMS and law enforcement overall, decreased spending on criminal legal system and medical costs associated with crises stemming from behavioral health needs, and improved perceptions of public order and safety within the community. So ultimately, these are performance and program evaluation questions we want to be able to answer both for the clients and for the community at large as a health department. And we will hopefully be producing that product by the end of next year, I would hope. So done.
Thank you so much, Amy. Great. That was a lot, throwing it at you all. Any questions or comments while we're still here? And Amy, you're still sharing your screen if you want to stop.
Good thing I didn't have pictures of my chickens up.
Laura, I'm not hearing any questions or seeing any hands up. Want to express my gratitude for the presentation. What a really, really cool presentation. Obviously, a lot of work's going into the already good work that you're doing, but quantifying it and being able to categorize it and get results back is huge. I have to admit that I'm a little bit peanut butter and jealous. I get to take a couple of your team members anytime, and permanent loan, we'll call it. But
No, you can't do that. But hopefully this is also about the data analysis that we need across all of our systems. And so I think this is also investing in that infrastructure and showing that it can be done, and having a global view as a community. So it does feel like we're moving in the right direction. And our hope is to have some dashboards that are public facing. And we also hope to be doing annual reports regularly for different task forces, as well as our county and city councils. So that's the goal. But we also don't want to roll anything out until we can really stand behind those outcomes. And obviously this is the process that we're in, and just very grateful for the HIA team.
Excellent. Does anybody have any other business? We don't have a quorum, so we can't really vote on anything, but does anybody have anything that needs to be brought up?
Still here. I just wanted to let you know, Caleb, our attendee has his hand raised again. If you
Okay.
want to do that, and then
Yeah,
I just wanted, yeah.
I was gonna say, I can't tell if anybody's actually in the conference room either, so.
Yeah, it looks like the conference room is empty. My only other business is just to mention right quick. Unfortunately we didn't get a quorum today, but I do understand this is the last index committee for both Wendy and Dave. So thank you both very, very much for all of your time and participation, and good luck on your future endeavors.
Indeed, thank you very much for noting that.
And Jason, go ahead and speak to the group.
Hi, thanks again, Jill. Jason DeForest here. Amy, what a great presentation. Thank you so much for everything that you do. Is there anything that you need from us as the community, or Caleb, from a police standpoint? What can we give you resources wise to make this an even bigger bang for your buck? We're here if you need us, is what I'm saying. I'm volunteering them as well. So thank you again.
Excellent. Yeah, I appreciate the willingness. Obviously, at this moment in time, we don't have a good answer for you, but we appreciate your willingness to step forward and offer resources. So we'll definitely consider that in due course. Any other business? We can adjourn. Thank you, everybody, for your time.
Bye.